Bonjour, ça me fait plaisir de prendre quelques minutes de votre temps pour introduire, en fait, pour commencer l'activité qui va se dérouler dans quelques minutes. Je me présente, mon nom est Youri Chassin, je suis député de Saint-Jérôme, donc membre de la CAQ, du parti qui forme le gouvernement, et par ailleurs adjoint parlementaire de Dubé, notre ministre de la Santé, parce qu'on m'a mis en charge comme adjoint parlementaire d'un dossier très spécifique, un engagement électoral qu'on avait pris à la dernière campagne, le dossier des mini-hôpitaux. Alors, c'est comme ça qu'on les a appelés un peu dans les médias, mais c'est une formule qui a collé et qui est très médiatique. Après ça, on peut imaginer plein d'autres façons de les nommer peut-être mieux. I'll talk a little bit in English because we have distinguished guests that are with us, and actually I'm thrilled to listen to their expertise, to their experience elsewhere abroad. This is something that will help us here in Quebec to implement these ideas. Basically, what we want to do is have the same kind of free access, the same kind of quality of care, but with one little quick change. It's going to be operated by someone who's not the public sector. So basically, this might change a few things, and we certainly hope so. It's probably the difference between the public and the private sector to operate things differently and maybe try something else that might inspire the public sector as well. Alors, je pense que ce qu'on a comme expérience au Québec, c'est effectivement d'avoir un modèle où le secteur public est beaucoup dans l'opération des soins. Évidemment en première ligne, mais ailleurs. Et on a peut-être là une expérience intéressante à mener. Évidemment, je ne veux pas prendre trop de temps. Moi, je veux surtout écouter nos invités. Mais ce qui me semble particulièrement intéressant, puis je suis sûr que vous en avez tous entendu parler, c'est qu'au-delà de cette idée des mini-hôpitaux privés, il y en a plein d'autres. On a le guichet d'accès, on a les cliniques du PS. Alors, évidemment, il y a plein de volets qui, je pense, permettent d'améliorer la première ligne, d'essayer aussi des modèles, de voir leur performance. Et ma partie à moi, celle sur laquelle je travaille avec les mini-hôpitaux, je vais être très intéressé, évidemment, d'entendre nos invités, mais de vous entendre aussi à faire des questions. Alors, sans plus tarder, let me introduce you, your moderator, Lysiane Proulx.
Merci, Monsieur Chassin. Merci beaucoup. Bonjour à tous. Thank you for your presence, Monsieur Chassin. We are happy to be here to talk about such an important topic, the mini-hospitals. As mentioned during Monsieur Chassin's introduction, mini-hospitals have the potential to improve healthcare access and also patient outcome in mainly underserved area, but across Quebec. But the way those new models are designed and implemented has a key impact on how the model will evolve. I have the privilege to discuss about this important topic today with three amazing panelists that have joined us from New York, Ontario, and Quebec. So before introducing our guests, I just wanted to introduce myself. My name is Lysiane Proulx. I am a consultant in marketing and strategy in the healthcare sector, and I am honored to be here today to moderate this panel with you. As you can see from this introduction, le panel se déroulera en anglais parce que nous avons des invités qui viennent de l'étranger. Mais si vous avez besoin d'assistance pour comprendre la session, il y a des appareils disponibles à l'extérieur de la salle. Sans plus tarder, I was just doing the intro about the language of the panel. I will introduce our esteemed guests, and I will look at my notes because their titles are so impressive that I want to make sure I don't miss any information. Our first panelist, Zayna Khayat is health futurist at Deloitte Healthcare. Talk about an impressive title, health futurist. She is also advisor at Teladoc Health, a virtual care company, and adjunct professor in health sector strategy at the Rockman School of Business. Welcome, Zayna.
Thank you. Et je parle français, je comprends tout, mais I'll talk in English.
Our second esteemed panelist, James Crispino, joins us from New York City. Principal Co-Global Health and Wellness Practice Area Leader at Gensler, a global architecture, design, and planning firm. Thank you, James, for joining us.
Thank you for speaking in English. Appreciate it. Thank all of you.
And last but not least, many of you know him already, Yanick Labrie, adjunct economist at HEC's Pôle Santé, associate researcher at the Canadian Health Policy Institute, and senior fellow of the prestigious Fraser Institute. Welcome, Yanick. So Zayna, Yanick, and James come from very different backgrounds, but they share a passion for healthcare. Some of them have had the opportunity to design, implement, or even evaluate mini-hospital models outside of Quebec or internationally. Some of them have also evaluated other healthcare systems. So to get the conversation started, I thought it would be interesting to hear a little bit about your perspective on the private mini-hospitals that you've encountered in the past, and also learn about some interesting or inspiring examples you've encountered over your career.
All right, so first thing to set the context. So as a health futurist, I kind of know what things are going to look like, and then it helps make much smarter decisions now. And very clearly, there's two big trends going on that is the driver of this. One is there's been a very long-standing trend of moving higher acuity procedures, services out of high acuity centers called hospitals into lower acuity sites so that there could be focus. The most analysts predict that your typical hospital will be stripped down to an ER, an OR, and an ICU. That's really what hospitals are for. High acuity, emergent, specialized, and everything else should happen somewhere else. So this is consistent with that trend. But the second reason you do that is this hypothesis, and I think it's been shown in most studies, that these centers, and they're being called mini hospitals here. I haven't seen that word, honestly, anywhere else, because the word hospital is ER, OR, and ICU. So I think we just have to be careful about language, just to be aware of, but I know why it's used, and we'll get into that. But the reason for that, the other is, of course, quality is the first, but also this expectation that by being more local and more focused on lower acuity, you're going to get better costs, so efficiency, much more consumer-oriented, much more of a better experience for people and staff because you meet them where their needs are and you don't keep pushing them to the side because you've got the heart attack that just came in the door. And the third is that you can, especially if you're building new, you build for the future. So you can be very tech integrated, very good with data, and most importantly, what we're seeing, and now this is with my hat working for the world's biggest virtual care company, is your hybrid physical and virtual from the beginning. So only the activities you need to happen at that freestanding hospital happen at that center, and the rest happens at home. You can design that from the bottom up. That is very, very hard to do with a 50, 60-year-old building that was designed for 7 or 8 parallel business models. Okay, so that's the trend, and I think this gives you an opportunity when you build new to do that and design for the future instead of protecting the past. The second trend is if you want to get those efficiencies, you want the quality, you want the access, you want to create a great experience, you want to be tech-enabled, you go to the private sector for building and for delivery. So I think we have to be very, very careful with this word private, because in Canada, as soon as people hear the word private, they think private pay, right? Private financing, which means you pay out of pocket. That's not what we're talking. So I think we should ban the word private. Let's find a new word. And the word I suggest we use is independent, right? So it's an independent third-party entity, which actually could be a for-profit entity. The healthcare org I used to work at, I was a chief innovation officer. We were a nonprofit private entity running outpatient centers just like these. You know, so let's be careful about that. So you go to these independent, I'm not going to say private, that are unaffiliated, because they should be able to be more efficient. You can decide how you will or won't pay them based on the results you want. So you can do a pay for performance type expectation. And most importantly, or maybe importantly, they spread the risk, right? There's a lot of risk with these. Financial risk, you need capital, and operational risk, clinical risk. How do you make sure you have the resources? Well, if you're going to a group that maybe runs 35 of these across the country, there's a lot more risk to pool than one little community in Quebec that's trying to do this with their available talent. So I'll just kind of set the stage on that, and then maybe as we get into it, I'll share a few examples that show features that have some highlights.
Great, thank you, Zayna. And James, what about you? Given that your background is completely different, what do you have to share with the audience based on your American experience?
Let's start with how these beautiful images and buildings get sort of formulated. I think Zayna did a fantastic job of kind of setting the table and the context for the kinds of facilities that we're talking about here. The fundamental strategy is to decant hospitals out into the communities, to take from the hospital all of the sort of non-quaternary, non-tertiary care that can be more easily and more efficiently be provided in the community, and to make that care more accessible and to have it perform based on metrics that are patient and family centered. So there's the one example I'm showing you here. This is in Brooklyn, New York, but we've done similar facilities outside of Boston, Massachusetts, in Istanbul, in Shanghai, and other places around the world. There are no beds in this particular facility. There is imaging, there are multi-specialty clinics, there are dental services, there are pediatrics and women's services, cancer services, and so on. So you can offer the various and different specialties that are needed in the community, but this operator is building 5 of these just in New York. And so the idea is to have them be widely distributed and have them be more accessible. One of the parameters they gave us to design the facility that you're looking at was a performance metrics, and we're going to touch on metrics as a group a little bit later in our conversation, but in this one in particular, the direction was to have the patients in and out of the facility with their prescription in less than 60 minutes, unless they were having a procedure. In and out with your prescription in less than 60 minutes. And so we designed the care delivery model and the clinical operation around that metric. And so one of the first things to go when you only have 60 minutes to treat someone and get them their prescription is the waiting room. There are no waiting rooms in this building. We call this pause waiting. It is essentially a nice wide hallway with a nice view of the city. It's, if you remember the image you were looking at a moment ago, you saw the red wall. That's the wall on the right there. This, the way this model works is what you check in at a kiosk in the main lobby, and it tells you which room to go to. So you are self-rooming. You go directly into that room, and when you check in the kiosk or with concierge with some help in the lobby, the physician or the medical staff who is going to see you is notified that you have checked in and are on your way to the exam or consultation or procedure room. This is one of the phlebotomy areas that is, these are adjacent to each of the clinical pods on every floor in the building.
You want to explain what phlebotomy is, just in case?
Sorry, does everyone know what phlebotomy is?
Sounds like lobotomy.
We're drawing samples, fluids, blood, so on, for clinical testing. This is one of those areas. These exist in each of the pods on the floor so that it's convenient for the patient and the family. Again, the entire experience and the entire clinical journey is really designed around the patient's needs and the physician and medical staff needs to efficiently meet those needs. And so it's that sort of intersection that drives this. And what's interesting, what I want to point out about this image is this is one of the exam rooms in the center. The photograph is taken from the door. So the patients come in off of a public corridor into the exam room. They've let themselves in. When you come into the room, it would be as if you went into a hotel room. On the screen, it would say, "Welcome, Zayna. You know, Dr. Smith will be with you in a moment." And through the door in the photograph is a common workspace for all of the physicians and the medical staff. All of the exam rooms are organized around that space, so it's easy for them to move between exam rooms and quickly and efficiently see patients, as opposed to having the rooms strung out for yards and yards along endless corridors. So this makes much better use of the medical staff time, as well as of the patient and family time. The patient satisfaction rates in this facility are over 98%. Wow. This is one of the dental operatories. It's on the 4th floor of the building, best views in the city, I think. And you can see it's a relatively simple organization. So the design itself, its materiality, how we use natural light, the signage, the wayfinding, the entire system is centered on the needs of the people who are in it, both the patients and families and the medical staff. And so I keep coming back to that because it's that kind of clarity, that kind of efficiency, focused on those metrics that actually can improve patients' experience when you can bring a high level of design as part of its implementation. So I have a lot more images. I'm going to stop there because I think I'm out of time.
Thank you, James. And Yanick, you don't build hospitals or design hospitals, but you know quite a bit about healthcare. So what's your perspective on mini-hospitals?
Merci. Dans un premier temps, d'être ici, c'est un honneur. I'll switch to English now. Well, I've been arguing in favor of allowing a larger role to private entrepreneurs for years, so you won't be surprised to hear me say that I welcome this initiative. Like Zayna said, the potential to improve efficiency, access to have a patient-centered care is enormous. In, I'd say, virtually every developed countries, you have a large role to private entrepreneurs in the delivery of care. Doesn't mean that people have to pay out of pocket. No, we're not talking about it. Like she said. Of course, there are a certain set of conditions needed to have that kind of benefits for patients. Well, first of all, I'd say you have to be transparent. You have to measure outcomes. You have to measure performance, and you have to let people know about those measures. So online, certain quality metrics. Every organization, be they public or private, be on the same level playing field. That's the first condition, I'd say. And with that, you have patients making better decisions, more informed decisions because of that. The second condition, I'd say, is to have money follow the patient. I mean, you have to give the incentive to the private entrepreneurs to try to improve the service, to attract patients. Otherwise, they don't get the money. Okay, it's obvious. It seems obvious, but the way our hospitals are funded currently on a global budget, it creates a lot of disincentive to treat patients in a timely fashion. And what else? There's another condition to have is to have the same set of regulation as well, because you have to, there's a role for the public sector, for the government, for oversight, making sure that you have good quality care for everyone. So of course, and with regard to the mini hospitals, I must be honest. I was hoping, I would have preferred that the initiative would grow from the bottom up instead of having a top-down process with a lot of conditions And I have some concerns about the way it's going to be deployed. Well, first of all, if you look at the call for interest, you probably didn't do that, but I did. I'm an economist, I did. And one of the conditions is to have it open 24/7, so it means overnight as well. Not sure it's going to be profitable for a group of entrepreneurs to take care of minor cases during the night. So that's the first concern I have. Secondly, how long is going to be the contract? When you invest a lot of money in building the facility, buying equipment, you have to know whether it's going to be profitable in the long run. And so far we don't know if the contract's going to be for a long duration. Okay. And thirdly, you have to have more than one single source of revenue. If you rely on, simply on government revenue, public money, might be hard to make it profitable. So those are my concerns, and I'll stop there. We'll have plenty of time to look at the international experience and see how they differ from what's in the plan. Okay?
Thank you, Yanick, for this introduction. As you can see, I didn't lie when I said that our panelists were passionate about healthcare and mini hospitals. And Yanick, as a great economist, has already taken us down the money trail. So we're going to keep talking about economics. As a preparation for this panel, we've had quite a few great discussions about success factors because, as we mentioned during the introduction, it's great to talk about a private mini hospitals, but the way it's designed and implemented will determine whether the model is successful or not. So based on this, I'm curious to hear more from you, Yanick, and our other panelists on economics and the role of the private sector in those private mini hospitals. We know that the cost of the mini hospitals, the current 2 mini hospitals, was estimated at $35 million per hospital, and that Mr. Dubé even mentioned in one of the press releases that we will have to make space for creativity for the private sector to be able to find revenue sources for as part of this model. So what's your perspective on this? And maybe Yanick, you already gave us some insight, but maybe Zayna, you had.
No, I can. Well,
go ahead.
Like I said in the introduction, in the opening statement, of course, the private sector is going to have to find other source of revenues. Otherwise, it's going to be hard because, well, it's going to be hard. It's going to be hard to be superior to the public organizations. I mean, and I'm not talking about extra billing and making patients pay out of pocket, not about that. But if you look at international experiences, it's very, very uncommon to see that kind of hospital having a single source of revenue and being able to innovate. If you look at Sweden, because I know a few of them in Europe. Sweden, you do have some primary care centers where, of course, the patient has to pay a small fee to get access per visit. It's very limited. But, they go there, whether they're privately insured or publicly insured, they're covered, get access to care. And the entrepreneurs, they have the assurance that if, the government in power changes, the party in power changes, they're going to have different sources of revenue, different types of clients, I'd say. And, because of that, it lowers your uncertainty. And it's the worst enemy of an entrepreneur. And in the investor, it's the uncertainty. So that's my concern for now. Yeah.
Maybe I'll just build on that. I think we have to think about the finances in two complete different buckets. There's the CapEx, so the capital for the physical building and the equipment, so that's CapEx, and then OpEx, the operating capital to keep margins and what have you. So So think about it, right? When you want to have any kind of a building, whether it's healthcare or a school, the amount of capital, if it's $35 million, you said, or whatever, your private entity needs to be able to amortize that cost over some period of time. That's what we've been doing with nursing homes across Canada forever. So they are kind of guaranteed some time to have that. What happened, if you follow what happened with Saskatchewan with their freestanding surgical centers, I forget the company that built them, but the way they did it was, I think they were on 5 or 10 year check-ins. So you're guaranteed in perpetuity, so you can get your capital amortized. But if you don't hit performance targets that you've all agreed on, if you do, you get right of refusal to go to the next 5 years, then the next 5 years, the next. If you don't, there's an opportunity to get out. So you've now really aligned incentives with the KPIs, the results you want. So I think there's just a set of conversations you're all going to have about the capital side of things. And then on operating X, everybody wants to like cry in the streets about, oh, they're going to charge privately, like you said, and extra services. I think it's a good thing if an independent entity that's bringing a publicly insured service to your communities has other businesses, because the R&D they're investing to get better at digital, to get better at care, they can now give the proceeds of that and the benefit to the community. I work for a private, separate, in one of my other jobs, virtual care company. We spent $400 million on R&D last year in virtual care. Not a penny of that had to come out of the Canadian market and Canadian healthcare. It got spent globally, and all the benefits accrue here when we bring our solutions into the market, right? So I actually think it's a good thing and not a bad thing around the money, but margins are going to be tight. So I see the risk, honestly, of more of, I find these mini hospitals almost commit what I call business model malpractice. Like you have an ER, you have outpatient services, you have imaging, you've got surgery procedures, a whole bunch of surgery procedures. Those are like 6 completely different business models. These entities that do these, you talked about in Sweden, the primary care one, in Saskatchewan and across Canada, it's just surgery or it's just urgent care. But to do 4 or 5 things in one place, that's a lot of different things. So you're not going to have one entity that can do all those. So you're going to have a builder who's going to, or operator who's going to have to contract 5 or 6 other entities into a consortium. And that's where I think the economics can get both diverse, but also very, very challenging. This is a bit unusual, this amount of mix of services.
Well, and I think what's going to drive the diversity of the providers is actually the health needs in the community.
Yep.
I mean, that's really where it needs to start. And I think going through that analysis, understanding what those needs are, how they are being met or not met by the system as it sits, is really where it begins for those who might be interested in developing or operating one of these mini hospitals. I think at the same time, having a clear set of performance metrics for each of the service lines. I mentioned, for multi-specialty practices earlier, having patients be in and out of the building in 1 hour with their prescription, right? So there was a pharmacy in the lobby and a nice little waiting area, and after you were done the consult and the physician made the order entry, it immediately went downstairs. The order was filled by a robot, basically, in the pharmacy, so it was waiting for you when you got off of the elevator. That's essentially how it works. But that's one stream in a system of many streams, right? And so when you're thinking about these metrics, you have to understand what the set of clinical possibilities are for a particular mini hospital, and how those, and what kind of metrics we need for each one of those. I would suggest that there is a core set of services that would be common to all of them. It might even help us just have this conversation, right? Because as we sit here at this moment, there isn't a common definition of a mini hospital. In fact, that it varies quite widely. So having a conversation around what that essential core set of services looks like, and I suspect it includes imaging, certain procedures, certain types of surgery, certain types of multi-specialty clinics, and things
and
like
urgent
that.
care.
And urgent care
It's a lot.
is a lot. it's a great place to start. It's exactly what will help the hospitals themselves sort of release some of the bottlenecks that exist in our existing emergency departments and in our surgery suites. But it's going to require a robust public conversation, I think, about what those services need to be, how we expect them to perform, and how those performance metrics are actually part and parcel of any contracts that are made between operators and developers and payers.
And I think we're going to hear a lot of discussion around this topic over the next couple of months. So really looking at how the hospitals are going to be funded, how they're going to be organized, around which services is key. But I'm curious to hear you about another hot topic, which is labor. So labor shortage is real across all industries at the moment, but the situation is critical in healthcare, specifically in Quebec. Obviously, when we talk about mini hospitals, one thing is building them, but staffing them properly is key as well. What is your perspective on staffing and also some of the concerns about talent erosion from the public sector to the private sector? Do you have examples from other healthcare systems or some insight on that topic?
You start?
Yeah, you want me to go
Wait.
first? Okay. Well,
Easy questions. So
I know.
The easy ones go to the economist.
No, the shortage is real, of course, but we often think that we live in a constant. It's gonna evolve in time. We're all aware of that problem. It's gonna take time. I mean, you have to admit more doctors. This is something that's gonna take a long time. But it's not only about the magnitude of the number of nurses, of doctors, is the way you use them. We often think that all organizations are equal in terms of how they use their resources. They differ in many ways. Management practices, the way they allocate their resources. The private sector, and I'm quite confident, if they have the flexibility to use their resources, they're gonna be in a better position to see more patients with a given volume of staff. So in the end, if you're able to use your operating room 75% or maybe 90% of the time instead of 50% in the public system, you're gonna have improvement in terms of access to care. And it's like I said, and if you look at the international experience, there's no correlation between number of doctors per capita and wait times to get access to elective care, okay? Because it's the way you use your human resources that matters most. Yeah.
I'll just build on that. So three points I want to make. So one of the risks with these, if you go to create more capacity because you have a bottleneck here, right, long ER waits, is that bottleneck isn't there forever. So for example, if you read the articles, they think, I think we have, I don't know, maybe 600 nursing homes across Canada, and all the baby boomers are turning 70, 75 right now, and they're like, we need double the nursing homes. But guess what? We're not going to need them forever, so we're going to go build all that. We're not going to build this infrastructure. And I think we have to be careful of building all this capacity for something that might start to go away. So I would be smart about projecting a little bit better, one. Two, absolutely, we have to be very, very careful not to assume that the work stays the same. That's the beauty of going new and having some new players. At Deloitte, we have a whole future of the health workforce framework. We're working with health systems around the world, and they come to us saying, help us hire more. No. We think of first, rethink the work, rethink the worker, their connection to healthcare, their meaning at work, the culture of work, the environment of work, how you pay them, everything about the worker, and then rethink the workplace. And you hit on those levers and you design where the best trends, where technology comes in, you will not need the same kind of staff complement we have today. You just won't. I think it's 30 to 80% less. So I think we have to be careful about worrying about staff. And then the third thing, in the UHN hospital, which is the biggest hospital in Toronto, when Ontario announced they're going to build these freestanding surgery and imaging centers, you know, he was very open. He said, I'm not afraid they're going to steal my workers. Rather, I see a great opportunity. So maybe one of my nurses does 3 days at our hospital with these very complex cases that make your career grow, get you excited, you're solving, and 2 days a week in the independent center, and you share the staff. Now that leads to a whole other set of issues around, you know I used to work for an independent nonprofit healthcare organization. I couldn't attract nurses to our organization, even though we were fun and we were sexy and we had good technology and we paid great, because they want to be in a hospital where they can get a pension and they have a union, right? So that is a really important, attractive feature that I don't know that these centers will have. So I think it should balance out, but let's see.
I would like to build on what you just mentioned. So leveraging technology, potentially automation, to leverage the burden on human resources. What's your vision? And I'm talking specifically to Zayna, knowing she's been heavily working on technology, but what is the vision, potentially, James, you've been exposed to that as well, for those mini hospitals or examples of leveraging technology to improve the patient experience and the staff experience?
Well, I think it's very much part and parcel kind of how they work, you know, and I agree with everything you just said about rethinking how people work, the tools they use to work, and so on. The technologies that we have available to us today to engage with patients, to engage with the families, that are available to clinicians to provide more effective care, are only going to become more sophisticated, but they're so robust right now. And they've so far outpaced most of the facilities that they live in, that the facilities themselves have become the rate-limiting step for clinicians and other medical staff to see the patients that they want to see. And so the building that I was showing everyone earlier probably has about 70% of the staff that you might find at a sort of typical multi-specialty outpatient center. But at the same time, the people who are going there feel more engaged by the staff that they're seeing. And I think it's because of the control, a lot of the control in the engagement between the provider and the patients is given over to the patients and their families. And I think that things that can be automated, highly repetitive, simple tasks and so on, like using machines to fill a prescription, for example, and making sure that they're filled properly, reduce the amount of time that a patient or family member is taking for their visit. At the same time, I mean, there was a lot of talk through the pandemic, of course, about telemedicine and so on. I think that's become table stakes at this point. I think there are there are advances in clinical technologies and procedures that are actually reducing recovery times for the surgeries themselves. I mean, just a quick example, 10 years ago, 15 years ago, a hip replacement was 5 to 7 days in the hospital.
Same day.
Today it's same day. It's the same day procedure. And it's one example of many, I think, to come. And so I think the really salient point is creating the health facilities that we need today and over the next 10 years that could be the libraries or the housing that we're going to need 20 years from now. Yeah. You know, in some rural communities, we've looked at facilities that are hospitals on Monday, Wednesday, and Friday, and are something else on Tuesday, Thursday, and Saturday.
Wow.
Because that's what the community needs, and that's what we can support. And so part of this is rethinking the integration of the physical and technological environment in a way that allows the communities and the people who live in these communities to use those facilities as they need them for the purposes that they need them.
I just want to build on that because it reminded me in the UK, I forget the name of the company, I think it's called Qubit. So when they had really long waits for surgery, they did these mobile surgery centers. They're literally on a truck, go to Chicoutimi, clear the wait list for hips and knees, take it back apart, go to Montreal, go to here, go to there. That's it. You don't need to build any more surgery centers. You clear the wait list and then you're starting from zero, right? So that's what we have to think
The
about.
other thing I'd like to add, if I
Yeah.
may, you know, you look at emergency department visits, and oftentimes, you know, I'll speak with hospital administrators and so on, and they'll say, well, you have to be careful with the emergency department because, you know, 60 or 65% of my admissions to the hospital are coming in through the emergency department. And that's largely true. That can be proven out statistically. But what the other half of that equation is that it's that group, that 65% of the admissions to the hospital only represents about 25% of the people who actually showed up in the emergency department. So what it's telling you is that the other 75% of the people who showed up in the ED actually could have gone to another type of facility. They could have gone to an urgent care center. They could have gone to another outpatient center. They went to the hospital. They went to the emergency department because it's familiar. They know what's going to happen. There's a certain common understanding about what they're going to get there. And we had this issue in the United States when urgent care centers first came onto the market about 15 years ago, and nobody was going to them. Nobody was going to the urgent care centers, even though the intent was to drain some of the volume and uncork the EDs, if you will. That's changed quite a lot over the last 5 or 8 years. And so you see robust networks now of urgent care centers like CityMD and VillageMD, and they're actually partnering up with primary care providers and with other multi-specialty providers to build these networks. So it is sort of a bottom-up phenomenon that you were talking about.
And I do want to cover that topic with you, and I see our timer run. I want to keep some time for questions with you, but you did bring up a very interesting point, at least interesting in my marketer perspective. And when we were discussing about success factor and usage, and we talk a lot about technology, staff, funding, but you brought up the importance of the community engagement, James specifically, but our other panelists as well, community engagement, staff engagement, patient engagement, but also the importance of communication and branding. I'm curious to hear your perspective on this, the importance of communicating the model to the main users and stakeholders in the project.
Okay, so one of the things that we found to be critically important is actually what we call community engagement strategy. And what we mean by that is, and we'll often start with this, I mean, most of our planning work recently starts with community engagement. And the community is broadly defined as the folks, the medical staff and administrative staff working at the medical center and the people that they serve. It's both. So the community is everyone, right? Patients, families, doctors, nurses. And historically what happened was, you know, we would develop a plan or a set of ideas around how to distribute services and so on, and then we would roll it out to the community and say, here's what we're going to do, what do you think? And most of us understand what the outcome of those conversations are. So we've kind of flipped the script on this conversation and started with engagement. What do you see are the clinical needs in your community? What do you see as the role of the provider in the community? Is the provider meeting that role? Do you understand what the provider does? In this case, the question might be, do you understand what a mini-hospital is? What do you think a mini-hospital should provide? What kind of services should be there? And to start to create a dialogue. And sometimes it can be difficult at first, so you have to be willing to work through that kind of initial, I've done this 100 times and nobody's ever listened to me bit. But to take the time to be engaged with the providers and with people in the community so that you can design a system that is understood. If you can create that understanding through effective communication, create that knowledge, create that awareness, you will find the utilization to be what you had hoped it to be and what you designed it to be, right? In the same way that Americans eventually learned that they could go to an urgent care center and not have to wait for 3 or 4 or 5 hours in an emergency department at a hospital to get exactly the thing that they needed. So we can create that familiarity through community engagement. We just have to be willing to do it so that, and let it be the basis for our planning.
Engaging the community, but also investing in a strong communication plan. That's it's great to get the message out there. And I see at the time running, we do want to hear you if you have questions about international mini-hospital models, or more specifically on the success factor. But before we open the floor to question, are there any international models you would like to point us to, or guidance you would have for our exploration phase here in Quebec as we look into the private mini-hospital models?
Well, if I may, it's hard to take one specific example from abroad and say, well, this is something we should emulate. It's always context specific, and James talked about the language, mini hospitals, and Zayna too said, well, it's quite unique to have that kind of facility, which is in between the hospital and the primary care clinic. And most of the time, what you see when you look at models abroad is that they tend to specialize in one specific areas, whether it's primary care, whether it's emergency services, and so it's hard, but still you do have some examples from abroad. And I talked about Sweden earlier. In Sweden, you do have some kind of primary care center with multidisciplinary teams. You have 5 to 10 physicians with nurses, physical therapists, and other specialists, and it's quite similar with what I think the government has it in mind. But still, it grew up from a bottom-up process, and the incentives are different. James just talked about the communication strategy, but in those countries, in Sweden, but elsewhere in Europe, in Western Europe and Northern Europe, you have, if you're a private entrepreneur, you have the incentive to try to attract patients because your revenues depend on it. Right. Currently in Quebec, if you do that, your budget remains the same, and you're stuck with a lot of people to treat and a long wait times. So when I say you have to, try to draw lessons from international experience, those are the kind of lessons you need to learn. Change the way hospitals and healthcare facilities are funded. Be transparent. Make sure that patients are well informed where to go, because right now many people just don't know. They show up at the ER of an hospital, even if they don't need to be there, even if we could treat them better elsewhere. So that's it, basically. Yeah.
Maybe I'll just add 2 comments. I think there's 2 things to learn from an international scan. So one is around the concept of provisioning using a private entity and key success structures. Well, that's been done forever in all contexts, so I don't think there's anything new we can add. We've been talking about that. And then there's the model. I think the only thing I'll say about using the private sector for providing care is Canada is very, very behind on the maturity curve of this being the way public sector engages with the private sector. So in the more advanced economies, like in England, Sweden, Denmark, Netherlands, they don't play I'm government and I'm going to procure a vendor to do that's not how it's called. Commissioning. Commissioning is when you partner with another entity to deliver a service to meet needs of a population. Everything James just said. A strategic commissioning governance model is very different from we're going to put an RFP to the tender to the public. And we're very low on the maturity curve. There's one province in Canada that Deloitte is working closely with changing their entire model to that. It takes many years. Then you have to have a stewardship model, not a payer model. So from procurement to commissioning, from payer to steward. A steward sets the governance, sets the rules of the game, and sets a way to change the rules of the game as you learn, right? It's very, as you said, you can't be top down and decide all the rules today and they have to stay forever. That's never going to work. Every community is going to be different. Technology is going to change tomorrow. Materials are going to change. So it's setting the governance role of a steward is very different from a procurer. So I would be encouraging to think and look and study those models, and we can work on those. In terms of just 2 things I'll say from international, in terms of the care model, whether it's the private delivering it or public, it doesn't matter. It's the model. I would really look at what Kaiser Permanente did. They've been on this journey. This is a health system about the size of Ontario in the US, to build these centers where they say you can be there 23 hours and 59 minutes, but you can't sleep overnight. And so how do they do that and get people out of hospitals? And then I would take a look at what happened in Brampton, Ontario, the fastest growing city in all of Canada. Their population's growing 10%. Their one hospital and one ER was doing a volume of 130,000 a year, and they had capacity for 90,000. So they built one of these. Not the private sector built it, but the operator's the hospital, the public sector. And all their assumptions about 24-hour urgent care, 8 to 8, I think is the design here for outpatient, got really tested in the real world. I'll just give you an example. They had to shut it down at 5 o'clock for many periods of time because they had no staff, even though they were supposed to promise 24 hours, right? So those would be some things I'd think about, is how do you adapt based on the model and the needs versus being very fixed.
I would just add, the Kaiser model that Zayna is referring to, Kaiser's based in California. They're worth investigating if you're not aware of them. But most of these centers offer a complete set of services, but they don't have beds.
Yep.
They just don't have beds.
It's a hospital without beds.
If you need more recovery time, you're going to be the first surgery that day. You know, you'll be first. But you won't be staying overnight. And if you look broadly at the utilization statistics, you'll find it's generally true that most people don't need to be in the hospital. They need good health care, but they don't necessarily need to be staying in the hospital for 24, 36, 48 hours.
Fascinating. So we might have a delegation from Sweden and from Kaiser Permanente at La Première Ligne en santé.
The German system is interesting as well because the money follows the patient, as you were describing. So the patient's basically deciding how the government's money being spent on their care.
Okay.
But the entire system is operated by private operators.
Very
The
interesting.
government doesn't operate.
Again, that's strategic commissioning. Germany, I forgot to mention them. They're another one. Very
personal
high.
favorite.
Yeah.
So quite a few pieces of insight and ideas for our exploration phase. But I see the time running, and we do want to hear from you. If there are any questions in the room, we are very fortunate to have expertise from different areas. So I would like to open the floor to the audience for questions. Si vous préférez poser vos questions en français, il n'y a aucun problème. On peut faire la traduction simultanée. Je n'en garantis pas la qualité, mais on peut essayer. Je vois une personne. Oui, pardon. Oh,
Hi, thank you for that. That was really interesting. One of the issues in Quebec right now is that our ERs are serving as a safety net for lack of access to primary care. About 60% of patients who show up in our EDs are low acuity patients, and they're showing up because they haven't been able to access primary care. So how do we ensure that these models don't get overtaken if they're highly efficient, highly accessible, low wait times? How do we avoid them being overtaken by this huge demand and kind of word getting out that they're super efficient to the population? And what have you seen in terms of like triage or intake of patients into these models?
You want to take that one?
You could start.
Well, first of all, that would be an absolutely fantastic problem for us to create, right? I mean, that way, if that actually happened, you would know you're going in the right direction. I mean, part of the issue with the ED is once you've presented at the ED has to take care of you, right? I mean, they're not allowed to tell you, oh, you don't need to be here, you can go see somebody around the corner. It's not an option for them. So I think part of it is creating different kinds of regulatory flexibility, if you will, in the system. I think as the demand grows, if the phenomenon that you describe actually takes place, you will find the operators and the developers come together just simply to create more of these centers because the demand will be there. That's what will drive the private sector development of the health system, is the demand for it. I think it's a bit delicate at the moment because it's a new idea, you know, and so it hasn't proven out here yet. But so that's why I think it's useful to look at Kaiser, look at other parts of the world to see where it has been proven out, because perhaps you have the opportunity to even advance that system. Show the Swedes something perhaps that they haven't learned yet. Right?
I'll just quickly, because I know maybe others have questions if you do get to the mics, otherwise I'm going to keep talking. I could do a 1-week conference to answer your question, just to be clear. 2 points. Primary care is not only urgent episodic response to symptomology, right? We believe that's it. So sure, you go to the ED when you don't have a doctor, and reminder, 15 to 25% of Canadians do not have access to primary care, and frankly never will if we keep defining it the way we do. So I think that aspect of primary care is 4 things. Sure, it's urgent and episodic. We just still make that 90% of the activity of your family doctor, but it's supposed to be 25%. The other is all your monitoring, proactive health, getting your screening before you're ever symptomatic. The third is all your chronic care management, ongoing. And the fourth is all your referrals to your specialists, et cetera. So in my other hat with Teladoc, like we've built a primary care model that is those 4 things from the bottom up. So you're not just treating it like ED. And then just last thing I'll say is we're working with a province right now that where we're actually, because like he said, people know what ER is, so they just go, like my kid has a bloody nose, I'm going to the ER. And there was a TV show called ER that didn't help things for a really long, okay, some of you kids weren't born yet, but there was in the 90s. Anyway, so I just think there's a way to triage from right there. If you don't have a primary care doc, we get you on the list. If you do, we send you home and you go do a primary care appointment for your CTOS 4 and 5. And I think these models are going to allow much better triage.
Yeah. The other thing I would add to the triage component, I was in one of the programs earlier today. It was actually in this room. I forget the title of it, but they were all EMTs sitting up here, and they were talking about
What's an EMT?
Emergency medical.
Paramedics. Yeah.
Sorry. Thank you. And they were talking about new programs that they were developing to understand whether or not somebody needed to actually go to the hospital. So it was this in-home approach to do a quick level of triage there, a greater level of triage than they had been doing historically. And what they were finding was that something like 70% of the people they were encountering didn't actually need to get in the ambulance and go to the hospital.
Yep.
That the paramedic could actually
The UK added that too. They're diverting 70% as well.
A more robust, whoever is leading that, and I apologize if you're in the audience, I don't remember your name, but you should be rewarded for thinking of this, and that kind of thinking needs to be advanced, needs to be supported and further developed so that you don't have the unnecessary use of very expensive resources, which is largely what this conversation is about.
We might have time for one very last question.
Yannick had a comment, don't you?
Oh. Yes, Yannick, go ahead. You still have, you get a minute. That's great.
That's a good and interesting question. And honestly, I don't have the answer. But that's the good part of it, because you have entrepreneurs who knows best. And why don't you start with so-called a call for proposals, like, in Europe it's widespread. Instead of having, I said call for proposal, but call for solutions. So you start with the objectives, what you want to solve. The problem is overcrowded emergency rooms. Yep. You're afraid that everyone's going to go to the mini-hospitals. Well, just let entrepreneurs bid on that, to compete on trying to find solutions to that kind of problems. And well, basically they would reverse the problem, but at the same time, I think it's the way to draw another important lessons from Europe. That's the way they do it. Instead of having restrictive criteria, this is what we want, this is what you should deliver. No, go the other way around.
And it would give Canadian physicians and entrepreneurs and others interested in the provision of care the opportunity to innovate in this space. Yeah. It's a great idea.
And I really wish we could have kept the conversation going much longer. As you can see, we're just entering our explorations phase. We talked a lot about the importance of creativity, making space to hear the community, the staff, the patients, exploring other models. And I sincerely thank you for your time, expertise, and for traveling all the way to Montreal for this panel. I hope the audience enjoyed the different perspectives On that note, once again, thank you, Monsieur Chassin, for this introduction into our esteemed panelists. We hope you leave this presentation with energized, motivated, and I will leave the last word to Monsieur Chassin. Thank you. And on that note, we wish you a great rest of the conference. It's coming to an end. There are still 2 activities, so enjoy the rest of the conference, and thank you for your participation today.
Good. Good job, you guys.